Good afternoon, everyone, and thank you for joining today's presentation, Preventive Care and Health Screening for Persons with Disabilities. First, I would like to review some technical components of this webinar. Please take a minute to orient yourself to the platform. If you would like to ask a question, please use the Q&A feature located on the right of the screen. Technical questions will be addressed as they come in, and content questions will be addressed at the end of the presentation. Live closed captioning is available at the bottom of the screen. On behalf of the Lewin Group, I would like to welcome you to the Disability Competent Care webinar. The Medicare and Medicaid Coordination Office at CMS has contracted with Lewin to develop technical assistance and actionable tools to support providers in their efforts to deliver more integrated care, coordinated care to Medicare, Medicaid enrollees. CMS is accredited by the International Association for Continuing Education and Training. They comply with the association's standard for continuing education, which is recognized internationally as a standard of excellence in instructional practices. As a result of this accreditation, CMS is authorized to issue the CEUs. To receive the CEUs, please complete the post-texts through CMS's learning management system with a score of 80% or higher. The link is on the screen to access the post-test. My name is Chris Duff, and I'm a disability practice and policy consultant who has been working with the Lewin Group to develop a disability competent care model and related webinars and materials. I will be joined today by Mary Lou Breslin and Dr. Judy Chamberlain. Mary Lou Breslin has been a disability rights law and policy advocate and analyst for over 35 years. In 1979, she co-founded Preventive, a leading national civil rights law and policy center, and presently serves as senior policy advisor with Preventive, focusing on the organization's healthcare initiatives. I'm afraid Dr. Chamberlain will not be able to be joining us today because she lives in Maine and she is still without power and phone service. So she has gotten me all of her narrative and notes, and I will be covering on her behalf as much as possible. But let me give you a bit of her background. She's a recently retired senior medical director for Aetna Medicaid. She received her BA and MD degrees at Stanford University and Dartmouth Medical School, respectively. She practiced family medicine in Maine for 30 years. At Aetna, her major areas of focus had been integrated care management programs, helping to develop clinical programs for Aetna's Medicaid members, with particular emphasis on biopsychosocial approach to each member and to fully integrated physical and behavioral health care for their members. We will also be joined by Gabriel Uribe. I believe I did not say it correctly, but I will improve. Independent Living and Diversity Services Manager at the Inland Empire Health Plan in California. IEHP has provided leadership nationally in the areas of member engagement and access. Lastly, we will be joined by Lydia Orth, who is a Presidential Management Fellow at the Medicare and Medicaid Coordination Office at CMS, who will share some of the strategies and tools developed for the flu vaccination pilot project in California. Next slide, please. We will start here with exploring the social determinants of health and their effects on the health and healthcare disparities experienced by persons with disabilities. We'll look at primary and preventive care, and then the barriers both providers and participants face in delivering or obtaining this care. We will close with a variety of strategies you can use to improve preventive care for your participants. All this will be followed by a Q&A. As this slide shows, individuals with disability are less likely to receive preventive care and health screening, despite being at higher risk for many chronic illnesses and secondary conditions. I would like to note at this time, though, that this presentation will primarily focus on adults with functional impairments, though the concepts are certainly applicable to the larger community of persons with disabilities. Persons with disabilities utilize a significant proportion of overall healthcare resources for their high medical and post-acute care needs. At the same time, they also represent the greatest opportunity to reduce avoidable episodes of care and thus costs. Healthcare redesign is focusing on participant outcomes, participant satisfaction and control, quality indicators such as immunization rates, and realigning financial incentives. Prevention, health screening, and immunizations are a crucial step to accomplishing these desired outcomes. When compared to individuals without disabilities, persons with disabilities are less likely to receive recommended preventive health services and screenings. As a population, they are at greater risk for poor outcomes, such as obesity, hypertension, falls, and mood disorders. Additionally, they are more likely to engage in unhealthy behaviors that put their health at risk. At this point, I will turn the presentation over to Mary Lou Breswin, who will discuss health and healthcare disparities as they are experienced by persons with disabilities. Mary Lou.
Thanks very much, Chris. So when we talk about health disparities, we're referring to a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on, for example, their racial or ethnic group, socioeconomic status, gender, gender identity, age, or other characteristics historically linked to discrimination or exclusion. For a very long time, people with disabilities were not considered a population that experienced disparities. It was assumed that poor health was a direct and inevitable consequence or outcome of impairment or disability. This perception began shifting as researchers and advocates delved into the reasons why people with disabilities experienced poor health. It soon became evident that poor health status was, in some situations, the result of factors not directly related to disability. The tide shifted at a federal policy level when agencies such as the National Council on Disability and the Office of the Surgeon General, the Institute of Medicine issued comprehensive reports that recognized health and healthcare disparities among people with disabilities. The Affordable Care Act also recognized disability disparities in a variety of initiatives, and the HHS Committee on Minority Health further advanced the idea of healthcare disparities in a very important 2011 report, which is a statement of principles and recommendations. The report concludes that by every measure, persons with disabilities disproportionately and inequitably experience morbidity and mortality associated with unmet healthcare needs in every sphere. Minorities with disabilities are doubly burdened by their minority status. So, as this report suggests, the intersection of disability, race, ethnicity, gender, and so on reinforces the role of social determinants of health in health outcomes for these groups with overlapping identities. Can we have slide 17, please? So what are some of the common health and healthcare disparities that people with disabilities often experience? They experience higher death rates from breast cancer and lung cancer and tend to miss benchmarks for mammograms, generally recommended every 2 years, and Pap tests, generally recommended every 3 years. Persons with severe mental disorders, or SMD, this would include schizophrenia, bipolar disorder, and moderate to severe depression, die 10 to 20 years earlier than the general population. This, I think, is a staggering statistic. The majority of deaths in persons with SMD are due to preventable physical diseases, especially cardiovascular disease, respiratory disease, and infections. Can we have slide 18, please? We know that roughly 50% of preventable deaths are attributed to non-medical indicators such as social circumstances, environmental factors, and individual behaviors, while 95% of healthcare resources are devoted to direct medical services, with only a small percentage being used to address these non-medical indicators. So once on the radar, it's really become important for us to better understand these non-medical indicators. Slide 19, please. Public health experts and disability advocates turn to the idea of social determinants of health, already being used as a way to understand disparities among groups of people who have systematically experienced greater obstacles to health. So what are social determinants of health, or SDOH? SDOH are commonly thought of as conditions that affect health risks and outcomes, and that may pose significant barriers to preventive care. So what role do they play in health and healthcare disparities among people with disabilities? Well, consider these interconnected factors: income and economic factors, social and community context, neighborhood. This may include limited transportation, lack of access to fresh food, lack of affordable housing. The built environment. This could include exposure to toxic substances, education levels, health status, physical and services barriers such as lack of physical access or accessible medical equipment, and even extent of provider disability awareness. So taking these factors into consideration, research has shown that those with disabilities are more likely to be unemployed, impoverished, have less than a high school education, and have higher levels of risk factors such as obesity, smoking, and being physically inactive. We have slide 20, please. But one cross-cutting factor really stands out in a dramatic way, and that's poverty. So only in the past few years has the powerful relationship between disability and poverty become part of the public discourse as it relates to health. This is an outgrowth of understanding that health disparities are not an inevitable consequence of impairment or disability alone. The SDOH model looks at the interaction of income, poverty, and disability. So disability is both a fundamental cause and a consequence of income poverty. Half of working-age adults experience income poverty have a disability. And this fact alone makes it possible to see the very powerful relationship between the two. So how does all of this affect health and healthcare, especially preventive services? Well, here's an example in the Medicare population. Medicare beneficiaries living with income poverty are less likely to receive preventive services across several quality metrics. This includes breast cancer screening, annual flu vaccines, adult BMI assessment, and managing diabetes. So in crafting solutions, we have to devise strategies that recognize the role of these powerful social determinants and that target pathways to interrupt the damaging cycles they set up. We'll be talking more about that a little later in the webinar today. So I want to just turn the presentation back over to Chris Duff, who will be talking about primary care and prevention.
Remind everyone, I'm filling in for Dr. Chamberlain. I'm going to be going over some notes she sent and also some previous conversations I've had with her over the last year. Many people with disabilities see multiple providers. Care can get fragmented with no single specialty provider taking ownership for the health education and preventive care of the individual. Everyone should have a primary care provider who is integrally connected with his or her specialty providers and who takes responsibility for health education, preventive care, age and gender appropriate screening, and care of common acute and chronic conditions. In addition, the primary care practitioner should screen for abuse, neglect, and substance abuse disorders and other health risks. Persons with disabilities may not be appropriately screened because it is physically difficult to do so. For example, not being able to stand on a scale to be weighed. They are also often not screened for sexually transmitted diseases because of an incorrect assumption that the person is not sexually active. It is common for providers to assume they are not, and in addition, not to screen for current or past sexual abuse or to ask if the person is sexually active with men, women, or both. This slide speaks for itself. Despite negative and unscientific publicity, immunizations are safe and highly effective. Immunizations can be given at any visit, even during an episode of acute illness like a cold or ear infection. As discussed earlier, fragmented specialty care may mean that no one provider makes sure the person with a disability is immunized appropriately. Children with disabilities may miss scheduled preschool immunizations because of multiple other appointments and procedures. Adolescents and adults with disabilities may not be made aware of critical immunizations or maybe assume that some are not needed, such as the HPV vaccine prior to sexual activity. 87% of individuals with disabilities reported experiencing a secondary medical condition. A critical part of primary care is anticipating and working with a patient to prevent secondary conditions, such as those listed on this slide. Specialty care may be focused on only one of these or on the acute treatment of a complication that has already occurred. It is far easier to prevent a complication than to treat it after it has occurred. Both Mary Lou and I will be sharing the providers and participants' perspectives and challenges on these next several slides. I will start with the provider's perspective. There are challenges to serving people with disabilities in a primary care practice, but most of these can be overcome with planning. It starts when the appointment is made. If a person is new to the practice, the scheduling staff should ask if there are any special accommodations he or she may need. For example, if the office has only one exam room with an adjustable table, it is critical that room be booked for that patient. If the participant has limited mobility, it may be helpful to have him or her come a half hour early to allow time to get into the exam room and be comfortably ready for an exam. Being a truly accessible practice goes far beyond compliance with the ADA and is beyond the scope of this presentation. We recommend practices educate their staff and also develop a panel of patients who have disabilities to work with the practice leaders. The next slide lists some of the common challenges, but just as a person with a disability is a distinct individual, the needs of each distinct individual needs to be identified and compensated. Now I'll hand it back to Mary Lou to talk about the participant perspective.
Okay, thanks, Chris. So my organization has conducted a series of interviews with people with disabilities across the country about their healthcare experiences. And we heard story after story about missed preventive tests and diagnostic screens. Many of these stories center around the lack of accessible medical equipment. Others reveal that providers sometimes rely on misinformation or incorrect assumptions about disability, as we just heard in Chris's remarks. And still others describe barriers preparing for diagnostic tests, such as colonoscopies, especially if the individual needs extensive assistance to carry out the pre-test routine. So here are just a couple of examples of the kind of remarks that we heard in our interviews about people's experiences attempting to actually seek out preventive care. So Mary, a Chicago resident and wheelchair user who had polio, had not had a Pap test for 5 years because she could no longer get on the high exam table at her primary care doctor's office. When she told her doctor she needed a table that lowered, her doctor said, "That's a really great idea. Go find one." this particular provider apparently wasn't aware or didn't think that she should play a role in trying to solve this problem. So, in fact, it took another 18 months before this person was able to identify a location where it would be possible for her to have the examination that she needed. We know that virtually every time we go for a doctor visit, our weight is measured, yet many people with physical disabilities are never weighed. In fact, most are never weighed. One of our interviewees, Michael, a New Jersey resident and wheelchair user who has multiple sclerosis, said in his interview, "I see quite a few doctors, and not one of them has a way of weighing me. The last time I was weighed was 10 years ago when I was still on my own 2 feet." My own personal experience with being weighed is similar to Michael's. The large medical facility where I receive care has an accessible weight scale, but it's bolted to the wall in an alcove, which blocks the access ramps. The staff who bring me into the office routinely say, "You don't want to be weighed, do you?" The last time I said I did, we tried to move the scale where the ramps would be accessible, which is where I learned it was permanently mounted on the wall, even though it was intended to be portable. Lack of insurance coverage or coverage of specific health benefits can also deter some people with disabilities living in income poverty from getting required screens or other prevention services. Other barriers frequently contribute, from lack of access to a primary care doctor, to transportation problems for people living in rural areas, to poor understanding of the reasons why prevention services actually matter. These examples of environmental barriers are common and stand in for other typical barriers to preventive care that people with disabilities often encounter. So I'm going to turn it back over to Chris now for the next segment of the presentation.
Thank you, Mary Lou. I appreciate your comments there. We're right on schedule, actually a few minutes early. So we're going to move on to the last main section of this presentation, and that is to explore a variety of strategies to improve preventive care and screening. First, I'll ask Gabrielle Uribe to talk about some work they've done in the Empire Health Plan. Gabrielle. Could you be on mute, Gabrielle?
There we go. Okay. So yes, thank you, Chris. So, as Marilee was saying, I think as a health plan, we recognized many of the barriers that, people with disabilities experience when accessing care. And one of the areas that we decided to address a few years ago was our entire urgent care network. We have a great resource for individuals who need to be seen, as many of our health plans have a resource for urgent care sites that need access to care urgently but not necessarily emergently. And we realized fairly quickly that our urgent care sites were experiencing a or people who were trying to access urgent care sites were experiencing disparities if they were deaf or used ASL as their primary mode of communication. So one of the things that we did is we strategized with local community-based organizations and talked about different solutions to this disparity. And we discussed the utilization of VRI, which is used in many hospital settings, urgent or emergent care settings. And we developed a project that would allow us to bring this technology into urgent care sites so that all those urgent care sites had access to communication for ASL users. And what we did is we funded tablets for all of our urgent cares in our networks. We required that all urgent cares have Wi-Fi coverage in their facility so that the tablets could be utilized for that purpose. And our results were great. Once we provided that equipment to the urgent care sites, we had virtual access, 100% access for our ASL users who are our members who are accessing facilities there. So it took us probably about 12 months to get this project off the ground and going. But we were able to not only provide equipment, we did some training on disability resources available to our members. We also talked a little bit about deaf culture and what to expect when individuals who are deaf access their clinics. And we learned a couple of things. We learned that it was crucially important for us to work with local community organizations that are ran by individuals who are deaf, who can give us some perspective as to the disparities in the experience that they have when accessing care at urgent care sites. And we also learned that the provider knowledge of the barriers that the deaf community faced was not very good. So we definitely provided some insight into that as we shared information. If we can go to the next slide. We also developed some easy-to-use training guides for staff. So we trained providers and we also trained office staff in cultural competency and provided them with resources on how to use the devices expediently, because we also recognize that many of these offices are in remote areas. We happen to be a health plan that's spread over a geographic region that's probably larger than the state of Rhode Island. And in many points of our two counties, there's really the population centers are not as dense as others. So we recognize that individuals who are deaf may not be accessing the services regularly, but we wanted to make sure that all the urgent care sites were ready to go and could easily pull out a guide to utilize the equipment when needed. The next slide, please. Another intervention that we are very proud of is our follow-up after a mental health hospitalization. So looking at mental health, one of the things that we realized early on was that there was a disconnect between the continuity of care after hospitalizations in mental health facilities and then the providing care thereafter. And our intervention was basically to follow up with mental health hospitals after we received the authorization request for services. And what we did is we worked with discharge planners our goal was to work with the discharge planners prior to the individual's release from hospitalization to ensure that we could schedule follow-up appointments expediently. One of the things that we learned while working with individuals who are part of this community was that they have many barriers. As Mary Lou was talking about social determinants and Chris was talking about social determinants, we know that a lot of our members who are Medicaid recipients have trouble sometimes accessing telephones, having a home phone or even an address. They experience homelessness, so they're either couch surfing or maybe living out on the street. So it's very important that we connected with a discharge planner while the patient was inpatient to ensure that we would have an appropriate follow-up. And the results were great. I mean, we saw about an 11% improvement from the previous year when we looked at our HEDIS measures for a follow-up within a week of the hospitalization. And then subsequently for within a month, we also saw close to or a little bit over 10% improvement as well, moving us on both cases about 25 percentile points up. If we can go to the next slide. So one of the things too that give me 1 second here. I'm trying to catch up on my slides on my end.
Gabriel, I think that was one of the slides that I was going to take over on.
Go ahead, Chris. That did not look familiar.
Thank you. So. Yeah, that's why I was trying to save you there. Yeah. Thank you. Actually, I have several questions for you. I thought your comments were great and really exemplifies what IEHP is. Preventive care strategies are really the core to success in integrated care. The first step to prevention is to build this relationship, educating participants about the importance and role of routine health prevention services and screenings. Most persons with disabilities see a variety of specialists, and often don't understand the need for a primary care practitioner. That is certainly our experience in Minnesota. Participants benefit from learning when and how to access their primary care practitioner and their care coordinator, both of whom can also provide training in self-care techniques. Some additional strategies include developing materials for the participant, highlighting the importance of preventive care and screenings. Many plans partner with local agencies, especially Centers for Independent Living, area agencies on aging, and aging and disability research centers to help with this education and to develop materials. Every community varies. I think the best way to figure out who to partner with is to look where your members go. Who do they look to for information? Care managers and care navigators, be them based in a health plan, a community organization, or within a primary care clinic, are critical in helping participants identify needed services and accessing them accordingly. These individuals are in regular contact with the participants and can be trained to assist with accessing preventive care. Additionally, call upon those who are already with the participant in their home, be it home-based primary care practitioners or home care staff. While most of these individuals focus on acute issues, they are in the home, they see what's going on, and they can be a great source of information to both from and to the participant. Another idea is to partner with local pharmacies to provide seasonal immunizations. Many persons with disabilities are in their local pharmacies frequently, and this could be a good strategy to providing access. Some health plans look at where their participants or members go on a regular basis and build upon these patterns. Look at where your members live or congregate, and work with public health or home care agencies to hold immunization clinics on site. Another approach along those lines is to partner with your community-based providers, such as adult day programs, to promote and provide immunizations. Now I will turn it over to Lydia Orth from CMS to talk about a special program pilot project they are implementing this fall in California.
Thanks, Chris. I'm excited to join this panel of amazing speakers to share information and resources around education and outreach to promote flu vaccinations. As Chris mentioned, I work at the Centers for Medicare and Medicaid Services office focused on serving beneficiaries who are enrolled in both Medicare and Medicaid. People who are duly enrolled in both Medicare and Medicaid have high rates of chronic illness and disability. As you've heard from the speakers on this webinar, many people with disabilities face barriers to preventative health, and information about and access to flu vaccinations is one of these challenges. Research shows that individuals with disabilities are 28% less likely to receive an annual flu vaccination than Medicare enrollees without a disability. 28%. That's startling. So, in an effort to address the disparity of people with disabilities accessing annual flu vaccinations, we are partnering with federal, state of California, and local stakeholders in an effort to improve access to annual flu vaccinations among low-income Medicare beneficiaries. This is a pilot in California. It is a multifaceted effort to raise awareness, promote education, and complement existing flu vaccination efforts. Next slide, please. We chose California because we wanted to leverage the Cal MediConnect demonstration. In the demonstration, participating health plans are accountable for providing both Medicare and Medicaid benefits for enrollees, and there are several years of work to build relationships and improve coordination among providers, plans, long-term services and supports, and community organizations. The overarching infrastructure gives us a unique opportunity to try to reach the populations that may not typically be reached by traditional public health campaigns, individuals with disabilities, as well as non-English speakers. Please visit Cal Duels for more information. You will see the link there on the slide. It includes a list of free electronic flu materials for your own efforts to promote flu vaccinations for a wide range of audiences. It also includes electronic copies of postcards that CMS mailed to 118,000 dually eligible beneficiaries in 11 different languages. You can customize and brand many of the materials that we have available on the CalDuals website for your organization. Next slide, please. We want to hear from you. We'd like feedback on where or what we should be doing to reach beneficiaries and other providers, as well as identify providers and organizations in California that will partner with us to disseminate flu education materials to your clients and partners. Please consider completing a short survey that we have located on the CalDuals website that was listed on the previous slide. Also, on this slide, we have a direct link to the survey to make it easier for you to access. Finally, we're seeking as many providers and organizations as possible to join us on December 6th in storming social media, newsletters, blogs, et cetera, promoting flu vaccinations. We'll give you content to use. We want to reach as many Californians as possible. Please let us know if you'll join the campaign. We would love to hear from you. My contact information is on the CalDuals Flu Campaign website, and we look forward to hearing from you. And with that, I'll give it back to Chris for Q&A.
Lydia, thank you very much. I'm going to follow up with a question right back at you. But first of all, I want to say that this is a pilot program in California. This is an issue that is certainly pertinent across the country. Plans have been struggling with this for several years with this population. So CMS decided to do a pilot with California counties and plans to develop some strategies, and then they're going to be evaluating it to see which ones are effective and how effective are they. So, Lydia, your question, is this pilot only in counties that have Medi-Cal Connect programs or all counties with Medi-Cal beneficiaries?
Thanks, Chris. That's a great question. This particular campaign is really just focusing on California. However, these materials we've called from CDC and other organizations that really focus on promoting flu vaccination. So it's not necessarily focused just on California, but in relation to the demonstration that we have in California, we thought that it would be a good place to have a demonstration.
Thank you. I have a question for both Gabriel and Lydia. You both have presented some material. Are you okay, especially the more member or participant-focused material, or even the provider-focused materials? Are you okay with plans or providers in other states taking your concept and ideas and maybe even some of the materials and adopting them for their use in their local community?
Hi, this is Gabriel. Absolutely, yes, we would be willing to do that. For us, one of the big learning experiences while doing this project was, working with different organizations who have been doing similar projects out in the community, not just in healthcare, but also publicly. There's organizations that have done access in different areas, whether it's telecommunications or, as Marilee was talking about, the access to accessible exam equipment, tables. We also did a pretty large project where we provided about 95 exam tables to our primary care network after doing extensive reviews of facility sites and making sure that people could get in through the door, that people can get into the exam room if they're utilizing mobility devices. So we would definitely be open to share that information.
Gabriel, this is you hit on another question we've gotten. I would trust that you have a lot more than 95 primary care sites in your service area. Did you have a criteria you used to decide where you would be willing to invest in some equipment?
Yeah, part of the setup of that project was to look at our entire region and geographically place or provide grants to primary care physicians and also specialists in different areas based on some of the data that we collected from our encounter information from our claims and utilization data. We also, looked at time and distance factors to make sure that those 95 tables covered a large coverage area. We had providers responding to certain questions. So we did a preliminary review of provider sites by asking basic access questions. We also looked at our PARS data, which is some data that in California we collect for accessibility measures out in each provider site or a large provider site or network provider site. And we leveraged all that information to do our preliminary selection of finalists. And subsequently, we followed up with an actual review of the site to make sure that it was accessible in collaboration with a consultant and also members of our team to ensure that that those would be appropriate sites. After the project, one of the things too that we learned was that we needed to let other providers know that this was available. Similar to Mary Lou's story about somebody, looking for a diagnostic exam, in that case a PAP exam, for example, and the provider responding in such a negative way, well, go find someone. One of the things that we want to make sure is that providers know about this information early on or through the network so that they can refer members if they don't have the equipment in their office, that they're able to also leverage other providers that are close by to have that access if they don't have that access immediately available there without having to go through so much red tape as well as far as referral process or anything like that. So as you know, those preventative exams are part of primary care, and as a health plan we ensured that people can access those without a prior auth or referral or anything like that, and that there's collaboration, even if those two providers are in different independent physician networks as well, as long as they're contracted with us.
Gabriel, what I really appreciate about IEHP is how strategically you guys go about things and how you keep your information open to the general public. And we will be hearing from, this one to others, we'll be hearing from Gabriel about some of their other strategies in a future one around access that we will be hosting sometime in the first quarter of next year. Another thing that IEHP does is they don't just provide a tablet or provide a table. They also provide some training and education for the staff there on how to use it and why they need to use it. So it's well implemented. So it's pretty impressive what IEHP has done. Lydia, I'm going to go back to you if it's okay. For the California pilot program, could California HHS reimburse for in-home flu shots?
I'm sorry, Chris, I didn't quite catch that question. Could you please?
For the California pilot program, would California HHS reimburse for in-home flu shots?
That's a great question, Chris. Medicare actually pays for flu shots.
They pay for flu shots, but they won't necessarily pay for a home visit for that. So that's I believe that would be part of the role of the care coordinator, is to get the member into a clinic or a setting, a flu clinic, or a setting where they can receive the shot versus sending a home care agency out to that individual's home.
Yeah, exactly. They'll work with their care coordinator.
Yeah, great. Okay. Then a question for, I think, Mary Lou. You used a word early on, which I thought was very interesting and very good. The word was intersectionality. Could you go back to that and talk a bit more about that? Do you remember where and how you used it?
Yeah, I think I do.
Good.
Sure. Well, I think the important message about intersections in relation to healthcare is that many of us belong to many different demographic groups. Our gender may be male or female or other. We may belong to different racial or ethnic groups. We are obviously of different ages. Many of us have a variety of disabilities, and we all sort of overlap and intersect in the same body. And so there has been a very important sort of evolution of our understanding of the intersection of these various demographic characteristics in terms of contributing to health and healthcare disparities, and disability is obviously one of those demographic characteristics, but not the only one. And various of the characteristics bring about or experience certain problems in terms of accessing healthcare that are unique to that particular demographic group. But when you overlay or intersect that characteristic with many others, then the picture is much more complicated, and the need for awareness of what the barriers are for each of the specific groups then has to come into play. So I think that many healthcare practitioners, public health professionals, researchers are taking a look at the role of intersectionality and trying to understand it and devise methods to improve healthcare services for these groups that experience many different memberships in different demographic categories.
Thank you very much. Another question for you, Gabrielle. And this is a question I would have no idea because I'd struggled with the same issue that the person's asking. How were you able to get behavioral health hospitals, providers, and their discharge planners in particular to buy in and partner with your care management team? This person said they seem to have huge barriers when getting responses from the hospital staff, and that certainly was our experience in Minnesota.
Yeah, that's a great question. It really starts from our efforts to really develop strong community relationships and have a group of team members who can, have these conversations, very candidly conversations with our two state. So in California, a lot of our mental health providers are managed locally by our county health departments. And we work very closely with our county health departments and have liaisons that are familiar with the process of both the health plan and the county system. And, just working through those relationships, having regular joint operations meetings to discuss some of the things that we both, or some of the goals that we both have in common, and, just working together and strategizing those goals, every quarter, it makes a great impact. It also, gives you somebody to pick up the phone and call if you have a need for a specific member on both sides. So I think that's definitely breaking the ice with public health departments, and definitely strategizing what the goals are and having very open conversations of that, and that usually leads to strong collaboration and partnership over the years.
Thank you very much. A question for Lydia. Is the pilot program for the flu vaccines in California only in California? Would you want other community health centers to participate in your study?
That's a great question, Chris. We would love for other community health centers to join into the campaign and share materials with us. My website, or my email address is on the CalDuals website, so if you go ahead and email me, I would love to find a time to set up a call and talk with you.
Thank you. Mary Lou, I'm going to go back to you. A question that has come in is, do you hear of much fear from participants or persons with disabilities of receiving immunizations, particular flu and vaccine and pneumonia vaccines? And if so, how would you characterize these fears, and how do you address them?
Well, I haven't had much experience hearing that people are afraid of having vaccinations. I'm more typically hearing that there are logistics problems actually getting the shot itself, and these logistics problems, I think, go back to some of the comments that Gabriel was making about or the circumstances of people with disabilities. They might be homeless, they might have difficulty acquiring the right kind of transportation, or they might actually not be able to leave their home, which was the example that just came up a few minutes ago, where they really have to have the shot brought to them, but there may be some cost barriers that prevent a provider from being able to accomplish that. Even with care coordination involved, there's sometimes barriers in that respect. So my response is that I think there's less fear of them and more concern about just how to go about getting them in a way that's actually practical and feasible and achievable.
That certainly makes sense from what we've heard and what I know other plans have tried to develop all sorts of strategies, and most of them are exactly about that, around how do you get the person and the vaccination connected. And so what you're saying absolutely makes sense. Another question for Gabriel. You're very popular today. Does anyone do you in particular have a teaching tool for helping people decide when to contact their primary care provider versus going to the ER?
No, that's a great question, Chris. I know we do have a series of videos that we have pushed out through our website that address that. And we also have had very robust promotions of our nurse advice line with freeway billboards or highway billboards. Also through our newsletters, we often talk about the appropriateness of that. A few years ago, too, we made it one of our big programs in home visits for families who had increased utilization in ER visits and also utilization on primary care and the durable medical equipment, which can many times be associated with disability. We saw that there was a need for education, just simply navigating through health plan and how to navigate and get resources from a health plan. So we developed a navigator program within the health plan that taught families as one of the units on the different needs or the different times they can access different levels of care, whether it's primary care, urgent care, and emergent care. And that was pretty successful. It did curb the utilization away from the inappropriate encounters that some of our members were having, and to more appropriate encounters with the appropriate level of care.
Thank you, Gabriel. Let me explore with Lewin. I'm aware of some resources that like June Kale's shop has done in Southern California, and I'm aware of a few other resources. And let me talk with Lewin about how we can get that out to make it available to people, whether it's just through the website, whether we send some information out to the registrants for this webinar. I think that's really an important piece in all of disability competent care. So let us get back to you all on that. Last question for you, Gabrielle. How did you reach the homeless and your participants with no phone numbers after hospitalizations and increased your compliance in the year?
So a lot of our when we're outreaching to the homeless population, we make sure that we make contact whenever somebody in our network is having a face-to-face contact. So we've trained our providers. We've made information available through our provider services unit, who is dedicated to providing resources directly to our provider network, and let them know that we can assist our members with connecting them to community resources, such as some of the subsidized cell phone programs that are out there. And we train them on those programs, and if they need further assistance with that, they can go ahead and also communicate with the health plan and refer the member to the health plan, or they themselves as a provider can connect with us, and we have a resource team that will fill in other gaps if needed as well. So we found that whenever we have an encounter, whether it's at a provider office, at the urgent care, wherever it is, that we have ability to do that, and then subsequently meet that person where they're at in some occasions. So there are also programs that are designed to, once the member makes contact outside of a clinical setting, that we're able to follow up with care out in the community as well if needed.
Great. I've heard from other plans that what they do is for these people, they put a trigger on their claim system so that the person shows up at a pharmacy for some medications or really shows up anywhere, it comes to the attention of their care coordination staff or someone who then reach out to that provider and let them know that they're trying hard to get a hold of this participant. Can they follow up in that way? So that's another possibility, is to go at it in that direction. I think you partially mentioned that in your comments, Gabriel. Well, our time is coming to a close today. Our next Disability Competent Care webinar will be reviewing the recently released update to the Disability Competent Care Self-Assessment Tool. We will have a health plan from Wisconsin and some folks from the state of Colorado talk about their experience in using the tool. The webinar will be on December 13th at 2 p.m. Eastern Time. If you're registered for this webinar, you will receive a notice for all upcoming webinars. We are also in the final stages of preparing the 2018 Disability Competent Care webinar series to provide users a more advanced look at some of the key disability competent care subjects, such as hospice care, working with persons with autism, and so on. CEUs will be available for those webinars. Check your inbox in the next few weeks or visit the RIC website for further information. For more information about obtaining CEUs, please visit the link on this slide. It will also be sent to all attendees shortly via email. Lastly, please take a moment to complete the brief evaluation of this webinar. A survey will pop up following the webcast. Help us to diversify our disability competent care webinars and address your current training needs. Your input is essential. We are especially interested in hearing from providers and plans at all levels of the healthcare delivery system. Again, I would like to thank the Center for Medicaid and Medicare Coordination for sponsoring this webinar and the entirety of the disability competent care work. And thank you to all the attendees of today's webinar. Goodbye.